insurance carriers, NTU would also recommend additional clarifying language to ensure that the funds recaptured will be dedicated to the FEHBP program and be used to keep enrollee costs down, as we understand DoD's TRICARE health plan does. Under TRICARE, rebates are put back into the insurance program and the PBM receives an administrative fee for services. NTU also believes the consumer protections in 4489 are a very positive step. The ones on drug switching and on selling claims data and on timely explanation of benefits. The PBM does not know what is best for patients, so the drug switching issue should go away, and the only way that should be able to occur is with appropriate medical input. We support an end to that practice. Now, on selling claims, while we question the practice of selling FEHBP claims data at all, at a minimum, OPM's concurrence should be a part of that process. And on EOBs, FEHBP enrollees will benefit from this added disclosure of prescription drug costs, enhancing their ability to choose the best plans for their needs. Finally, NTU would support adding language to 4489 to provide a pilot test of statutory pricing. We have long believed that OPM should investigate the possibility of buying prescription drugs off of the federal supply schedule, as we've heard that the VA and Defense do. Their drug prices are substantially lower than FEHBP. 10 years ago, I testified before Congress in favor of a small pilot that OPM had approved for the SAMBA health care plan to allow access to the federal supply schedule for its mail-order drug program. SAMBA argued it could save 3% annually in enrollees' premium shares by directly buying from the government. Overall savings would have been $2.4 million annually, and that was back in $2,000. Despite OPM's approval, the pharmaceutical industry, whose profits 12 years ago were estimated at $26 billion, pulled out, and they refused to participate in the plan. NTU would support a demonstration project to examine hard numbers associated with the direct purchase of drugs through the FSS, and we would support adding a provision to H.R. 4489 to make that happen. I believe this approach offers a real opportunity for cost savings. I thank you for the opportunity to testify today, and we'll be glad to answer any questions.
Thank you. Mr. Calfee, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. It's a privilege to speak at these hearings. The views I present are my own, not those of any organization, including the American Enterprise Institute, which does not take institutional positions on specific legislation, litigation, or regulatory proceedings. H.R. 4489 focuses on the role of pharmacy benefit managers, or PBMs, as we have heard, in federal employees' health benefit plans. On the whole, the provisions of 4489 would do far more harm than good for consumers and patients and would increase healthcare costs. This bill is based on the assumption that competition does not work well in the PBM market. The facts belie this premise. Competition is vigorous and multifaceted. Standalone PBMs compete among themselves and also compete with retail pharmacies, large health insurance plans, large employers, and even pharmaceutical manufacturers themselves. In this highly competitive environment, employers and insurance plans have negotiated a rich variety of PBM contracts that reflect the specific preferences of the contracting parties. Another indicator of vigorous competition is the fact that a detailed investigation by the FTC, the Federal Trade Commission, found very little evidence of favoritism or self-dealing on the parts of PBMs, regardless of who owned the PBMs. 4489 would force nearly complete transparency in the financial arrangements between PBMs and their partners. This would be difficult to achieve. But if the legislation does bring this kind of transparency, it would undermine the incentives of PBMs to negotiate discounts from pharmaceutical manufacturers. This has been recognized by the FTC staff and by other economists. 4489 would also require PBMs to pass on virtually all the savings they realize from aggressive cost cutting. This would undermine the incentives to cut costs in the first place. This cost cutting comes primarily from negotiating rebates from pharmaceutical manufacturers. Undermining these incentives would raise costs. This adverse consequence of regulation has also been recognized by FTC economists and by others. 4489 would also establish price controls, which rarely, if ever, does good in competitive markets. The prohibition on negotiating a spread between payments to manufacturers and to pharmacies would discourage PBMs from seeking to reduce drug prices and costs. Giving OPM the power to set ceilings on pharmacy dispensing fees would require OPM to uncover the true costs and benefits of dispensing for pharmacies. This is not easily done, and it could easily disrupt access or even increase costs. 4489 would prohibit health plans from reimbursing more than what is called the average manufacturer price, or APM, and OPM would be granted new oversight powers on drug pricing. There is no reason to think this would reduce prices directly, because manufacturers can adjust prices outside of the FEHB system. But this measure could easily set the stage for direct price controls over pharmaceuticals, as we have already heard. This would have extremely adverse consequences for researching and developing new drugs and new uses for approved drugs. 4489 would also impose restrictions on who can own a PBM. This would tend to reduce competition. In addition, these restrictions would deprive the marketplace of the benefits of vertical integration. For example, ownership restrictions would sometimes add extra steps in the pricing of drugs as they proceed through various channels from manufacturers to patients. 4489 would also expand regulation of drug formularies. Little, if any, evidence indicates that PBMs harm patients through the design and operation of formularies. New restrictions are more likely to raise costs than to improve health. Finally, 4489 would grant OPM the power to prevent PBMs from selling information on drug utilization and sales. This would be unfortunate. This kind of information can play an important role in the larger task of improving pharmaceutical targeting and use. And again, there is little, if any, evidence of consumer harm from these practices. For all these reasons, I respectively urge this committee to reconsider 4489. There is no reason to prevent employers, health plans, and pharmacies from negotiating whatever arrangements they wish with PBMs. Thank you, Mr. Chairman.
Mr. McNeely, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, members of the committee, I very much appreciate the opportunity to come before you today and testify about this bill and its effort to control drugs and the cost of drugs in the Federal Employee Health Benefits Program. As I said, my name is Larry McNeely. I'm the healthcare advocate with the United States Public Interest Research Group. U.S. PIRG, as we call it, is a national federation of state-based consumer advocacy organizations. We have a 35-year history of standing up for consumers, and we're convinced that both strong competition and strong consumer protection are essential to the functioning of any market. Unfortunately, the pathway for pharmaceutical delivery in this country, the market for pharmaceutical benefit managers, PBMs, lacks that adequate competition, and it lacks the consumer protections that are required. And that's why the reforms envisioned in H.R. 4489 are so necessary to help bring down costs. And in explaining the benefits of transparency, I think a lot has been said in this panel and the previous panels. I just want to refer to the comments of Assistant Attorney General for Antitrust, Christine Varney, who highlighted its importance when she said, "I am a firm believer in what Justice Brandeis said in another context. Sunlight is said to be the best of disinfectants, electric light the most efficient policeman. Markets work better, and attempted harms to consumers are more likely to be thwarted when there is increased transparency to consumers and government about what's going on in an industry." I could not say it better. In my written testimony, I go into more detail, but just to outline a couple of the essential points. If the three essential elements of any competitive marketplace are choice, transparency, and a lack of conflict of interest, the PBM market actually lacks each one of those three. It's highly concentrated. We actually have some evidence, which I detail in here, of legal action to stop deceptive and fraudulent practices. And we continue to see these practices of drug switching and self-dealing, which are not only unfair to federal employees in this particular context, but are spread more broadly across the healthcare market, and we really think needs addressing in other legislation. We believe enacting H.R. 4489 will lead to significant cost savings for taxpayers. The proposed legislation will actually lead to a reduction in pharmaceutical costs by requiring the pass-through of rebates and prohibiting the practices of drug switching and spread pricing. And it will protect employees and taxpayers by preventing conflicts of interest that we've run into in cases like CVS Caremark, where a PBM is owned by a retail chain. These assertions are backed up by a growing body of evidence that demonstrates that plan transparency does allow plan sponsors to monitor and curb their prescription drug spending. I detail a number of examples, but in one case in New Jersey, when they switched to a pharmaceutical benefit manager contract that was transparent for 600,000 covered employees, they're now projected to find $558.9 million in savings over 6 years. If we're talking about 8 million federal employees, certainly a substantial amount of resources are available. And just to sum up, I think, our attitude and why we're, I think, so grateful to the sponsors of this legislation for moving it forward, is that without the protection afforded in H.R. 4489, it's as if the pharmaceutical benefit management industry is saying to taxpayers, saying to federal employees, give us $10 billion of your money and trust us. The PBM industry as a whole, as we demonstrate in some of the lawsuits that I detail in my testimony, has not earned that trust. And we should make sure, I hope this legislation gets favorable consideration by the committee. Thank you.
Thank you, Mr. McNeely. I now yield myself 5 minutes. I want to thank you all for your testimony. I really appreciate your willingness to come before the committee. Mr. Calfee, I have great respect for the American Enterprise Institute. They have long been advocates of good government, I think. And I'm a little puzzled. I know that you testified previously before the House Energy and Commerce Committee to the effect that that prescription drugs in the Medicaid program should more closely reflect costs. Now, during today's hearing, you have heard both Republican and Democratic members express the frustration that we cannot determine what the costs are of the drugs in the FEHBP program. We have heard from the customers, the users, that they cannot determine what the costs are of the drugs offered in the FEHBP program. We have heard from the Office of Personnel Management, responsible for oversight of the FEHBP program, that they indeed cannot determine what the costs are of the drugs in the FEHBP program. We've heard from the Inspector General of the OPM, who says, and he is principally responsible for the oversight here, that he cannot determine what the costs are in the drugs for the FEHBP program. And we even have an example of a program where 300 drugs are offered to the general public with no insurance, and they are paying less money than insured individuals are paying through their pharmacy benefit managers in the FEHBP program, which is funded on an average 72% by the taxpayer, roughly 28% by premiums paid for by the individual. Why would you support, the principle that Medicaid drugs should be, as closely as possible priced based on cost, and yet your testimony here today seems to be at variance with that, if not directly opposed to it?
You're referring to my own testimony in connection with Medicaid?
Yeah.
I'm trying to remember what I said, but I imagine what I said was that the Medicaid should pay market prices rather than getting a special fixed discount from market prices. But they should go out in the market.
We testified in 2005 before the House Energy Commerce Committee. It says closely reflect costs.
By cost, I was referring to market prices. Certainly, I was not referring to the cost of manufacturing the drugs, because those costs are very, very small compared to any prices. But my understanding, especially from the testimony of Mr. O'Brien earlier today, is that all of these plans are free to reach contracts with PBMs that do provide for disclosure. In fact, I believe that's what Argosy Systems specializes in. And so my understanding is that if a plan wants to have transparency, if they want to have the rebates passed through to them, they can arrange through that. They can arrange for that through contracts. And so I think the issue here is whether or not they have the freedom to either have a contract that does provide for transparency and pass through rebates, or to have a contract that doesn't do that. And what we've heard in the private sector, outside of FEHB, is you get both kinds of contracts. You get contracts with transparency, ones without, et cetera, et cetera. The plans experiment with different ones. Sometimes they save money from when they switch to one approach to another, and sometimes they don't.
But sir, in this case, we are the customer. I am a federal employee. I am an oversight officer on behalf of the federal employees. It's not as if we said we want a contract with no transparency. We're demanding transparency, and we can't get it. Nor can the Office of the Inspector General. We can't get that transparency. Nor can the Office of Personnel Manager. We can't get that. The PBMs and the contracting parties here are saying that it's a matter of proprietary advantage, and they don't want to disclose that. So we have had instances where it's gone to court in the state of Maine example, where I think the heat of that litigation broke the case open for the state of Maine, and it was a great advantage. But absent that urgency and the consent decree that was rendered in that case, that transparency would not be forthcoming. So it's not like, we'd prefer transparency, or we would not prefer transparency. We're demanding it, and we cannot get it. That's the truth of the matter here, on behalf of everyone that I mentioned, Republican and Democrat, so far.
Again, I know in the private sector outside of FEHB, it's fairly common. It's not the rule, but it's fairly common. It does happen that a plan will have a contract for transparency, such as with Argosy Systems that we heard about earlier. But if you think about negotiating, a PBM negotiating with a drug manufacturer, if it wants to get a discount on a certain drug, and if that manufacturer knows that any discount he provides will instantly be communicated through the plans to other drug manufacturers, and the other manufacturer will probably offer to match that price, then what the manufacturer knows during the negotiating process is there really isn't much to be gained by the manufacturer by providing a discount, because they will end up having to give that discount to everyone. So I think it's economic reasoning does suggest that if you force transparency, you can make these negotiations more difficult, discounting more difficult to obtain. And I think that's fairly close. I wouldn't call it a consensus, but I would say the bulk of economists follow that line of reasoning, including specifically the Federal Trade Commission and also CBO.
I appreciate that, but I think we did hear testimony here today, and in my bill specifically, it's not requiring public dissemination of proprietary interests here. We're talking about you need to tell the Office of the Inspector General for OPM. They already receive proprietary information. They guard that jealously. And in fact, if that information got out, it would hurt their credibility enormously and affect negatively their ability to do their job. So that's why we're suggesting it just be limited disclosure. Let me go on though. Mr. Adcock, I know that you mentioned earlier the number of NARF employees that are included under the FEHBP program. Let me ask you, what's the general assessment in terms of your own employees, your own members, attitudes towards the current FEHBP program, specifically towards OPM's oversight of prescription drug programs within the FEHBP?
Well, I think it's kind of a love-hate relationship. On one hand, I think that they're happy that they have health insurance that's equivalent to what other large employers provide, but I think they hate the fact that they're paying premiums in the double digits for the last several years. With regard to prescription drugs, I mean, I think they understand very clearly that that is one of the huge cost drivers in the program and responsible for huge premium increases. Now, I think that over the years because of the fact that several years ago they were encouraged through cost sharing to start using mail order prescription drugs, and thereby pharmaceutical benefit managers, and they're now accustomed to doing that. I think that where there's concerns that we hear most often is that when we hear examples that individuals that don't have any insurance at all can go into a drugstore and get a better price on a specific type of drug than they can through the insurance, that's troublesome to them. When they hear about that state attorney generals all over the country are involved with legal action against pharmaceutical benefits, that's troublesome. And so, on one hand, I think that when you're talking about the customer service that they have with pharmaceutical benefit managers and arranging for their drugs to be purchased, I think a lot of these PBMs have very good customer service. But when they hear about these stories, they want to know what's going on behind the curtain. And that's why I think for a lot of them, they're very interested in the subject matter of this legislation and transparency.
Dr. Simon, can I ask you the same question with respect to, I know the American Federation of Government Employees has a tremendous amount of employees affected as well. What are the attitudes? I don't know if you're close to that level of feedback, but...
Oh, I am, but I just want to say, especially in light of the oath that we took at the beginning of the panel here, I never finished my dissertation, so I'm not Dr. Simon.
Okay.
But in any
All
case,
right. We won't hold that against you.
But thank you for the presumption. In fact, AFGE is holding its annual legislative conference this week, and during the issues briefing this weekend, I don't think there was any subject that raised people's hackles more than what's been going on in FEHBP. Wow. Part of that is because of the national health care reform bills that would impose a so-called Cadillac tax on their FEHBP plans, and I think today's hearing shows that there's nothing about the benefits that make it a Cadillac. It's the fact that we pay too much. The price is too high, but the benefits aren't necessarily luxurious or comprehensive. And so if that goes forward, they'd get hit again for something that's completely beyond their control. We often, when we testify on FEHBP, note the fact that we don't know the number exactly, but there are at least a couple 100,000, if not more, federal employees who are eligible to participate in FEHBP but don't participate and don't have insurance from another source because they can't afford the premiums that are on average now 30% for the enrollee, and they keep going up. And so many of our members work in veterans hospitals or in prisons and DOD medical facilities where they may be providing these prescription drugs to inmates or patients in the veterans or patients in the DOD hospitals, and they know that the same government that's paying for their health insurance through FEHBP is paying one price if they were prescribed that drug, and a completely different price when they're dispensing it in a VA hospital or a prison or through the Indian Health Service. And they're very, very aware of the fact that FEHBP has not been run in a way that would minimize the cost to taxpayers or enrollees. And as it gets more and more expensive, and each year as a higher and higher percentage of overall premiums is shifted onto the employees, they're livid. They're livid. They're getting a small pay increase, and their FEHBP premiums are going up, and they're not. They like this legislation.
Okay, thank you, President Kelly. I know you've got a pile of employees that are also affected all over the place, right?
We do, Chairman Lynch, but it does come down to the single issue of the cost of the plan, and because everything points to the fact that these annual increases are so directly tied to the cost of prescriptions. And I would also say that the forum that you held last September, on this issue, for those who did not know about the federal supply schedule and the prices that were being paid so differently at DOD and VA, they know that now, and they have more questions about why that would be allowed to continue to happen, and why OPM, the question has always been what OPM will do to better leverage the 8 million enrollees. And of course, like I said, it always comes back to the prescription drugs is the one element that is always pointed to when the annual increases are announced each year.
Well, let me ask you about that then. We had this forum. I guess I had an inclination to try to do the simplest thing, which we have a government purchasing system under the FSS, that federal supply schedule, and it's fairly it's well known. It's well used. It's established, and it's used in general government purchasing, and it's fairly transparent. You put it out there what you're going to charge the government for providing a certain material or service, and it's competitive. And my thought was, rather than this very, very Rube Goldberg type construction that we've got for federal employees' health benefits on the pharmacy side, let's just put it out there like we would for widgets. And you offer your price to the government, and we accept it or reject it. We can consider quality and level of service. Let's just do that. And the PBMs were the loudest critics of that system because it would eliminate them from the whole process, basically. At the same time, now that's a very crude solution to our problem. It simplifies things, but I'll take for granted that widgets are not the same as pharmaceuticals being recommended by a physician for the health care of that individual, and there's some important differences there. However, when you look at the VA system that's out there that works pretty well, they have a fixed formulary, however. So there's a more limited choice, although there are waivers under certain circumstances. How would your members respond to that if there was a fixed formulary? Because that's going to reduce, conceivably, it's going to reduce some level of choice for some of these, exotics or some of these less commonly used pharmaceuticals. It's going to be a limitation on choice. How are they going to balance the likes and dislikes of a system that might have a fixed formulary but a much lower price across the board?
I don't know how they will react to change in general, but any kind of a positive change I think would be received. But one of the things that NTU has recommended is that this be done as a pilot, that it not just be an across the board, because then all of the benefits that we already know exist, such as a transparency,
right.
For those who oppose it, it's already there. It's the obstacles that they're raising have already been overcome with the use of the FSS. So let's try it in a pilot in one or two of the plans in the program, and see exactly what kind of an impact it would have, and if there are other issues that are created that haven't been thought about.
Like I said, there are waivers, or there are ways to, if something's not on the formulary, if you make a showing that this is needed, then there's a way to get around that. But it does put sort of a gatekeeper on the formulary. Mr. McNeely, you had some great testimony earlier on about competitiveness and transparency. Are there items, as you look from U.S. PERG's standpoint, are there items that should be added to this legislation that we may have forgotten, or that you might think would be helpful?
Yes, and we'd be happy to work with you, but We generally believe that there's some steps that will be taken to strengthen the consumer protections within FEHBP by establishing an ombudsman and some other measures, which I'd be happy to work with the committee in terms of those suggestions.
An ombudsman in what respect? With appeals to which body? The carrier, the pharmacy, the PBM? It's okay. You know that.
Yeah.
Well, I'm getting a little deep in the weeds here, and I don't want to put you on the spot.
Okay.
Okay.
Thank you.
Are there any other matters that we've overlooked here in terms of trying to, as I said at the outset, this legislation is not etched in stone, and we've heard from both panels, all three panels actually, I think constructive recommendations that we could improve our bill, and we're happy to do that. But are there other items that you think? How about the suggestion that was made by Representative Treat from Maine about importing a standard of fiduciary responsibility on the part of the PBM to act as fiduciary on behalf of the plan, of the insured, the participants? Any thoughts on that?
The imposing a fiduciary duty on the insurance carrier or on the PBM?
PBM.
On the PBM. I guess I don't know enough about what kind of responsibilities that would involve and what the checks would be in terms of the oversight on the employer to ensure that they were actually complying with those fiduciary duties. I mean, obviously, you know, as an employer, you're a fiduciary or should be at least a fiduciary of your health plan on behalf of your employees and retirees. But I'm not sure exactly how that would work with a PBM.
Well, I think what they're trying to get at is this. You're hiring a pharmacy benefit manager to get you the best deal. That PBM goes out there, negotiates a deal for you as your agent. But unbeknownst to you, because of the way the system works right now, they pocket part of the advantage that you paid them, you've already paid them as your agent to go out there and get a good deal. Then they get you a good deal, a great deal maybe, but then they pocket part of the advantage and come back to you and give you some measure less than what you paid them to get you. And so, you know, that sort of gives a little bit of a snapshot on the problem here, right, that these deals are all going on, and you never know what the real cost, as Mr. Weiner testified, you never know what that bottom line cost was. But with a fiduciary responsibility, it would make it clearer that the benefits flow to you, that person, that PBM is out there negotiating for your benefit as your agent, and it would require full disclosure of any advantageous relationship that they engaged in that may be in contravention of your own interest.
I guess my question would be is that if there is such a fiduciary duty, what sanctions would be made against the PBM if they breach that duty?
There's a great deal of case law that's been developed around the responsibility of fiduciary responsibility, and I think that would all be imported. Those standards would be implied, or not implied. They would be applied if we import the fiduciary relationship, you know, with respect to a PBM and the people that you represent. I think. Okay. You know what? I just want to ask you each if you have anything that you'd like to add. We have this is a series of roll calls, so I don't want to. I would rather be able to dismiss the panel and adjourn the hearing than come back. So I think we're probably at that point anyway. You've suffered enough. Ms. Simon?
Oh, well, I just would say very quickly, I think that this idea of imposing fiduciary responsibility on the PBM makes it makes it even more important that we would have the cost and pricing data that would be triggered by application of TINA, the Truth in Negotiations Act. We would find out what prices they were charging to all their customers and what the actual cost of production of these drugs is, and that when, in many cases when you're buying drugs, it's a sole source contract. And that's what triggers the applicability of TINA, where you find out this data. Again, a proprietary data that would be held by the agency, so it wouldn't be made public, but it would allow it would allow the government to enforce this fiduciary standard on the PBM. So either way, we need this data. We need this information.
Okay, great. President Kelly?
I will be looking more at the main experience and at that language, but it just seems to me that that language on fiduciary responsibility would add to the transparency, which is the goal of of the legislation, and that would be an enhancement to it.
Yeah, it's my reading as well. Mr. Calfee, please.
Yeah, I would suggest that the most dangerous and counterproductive part of this legislation is the pass-through. If you say to a PBM, we want you to go out and negotiate on a really good discount, negotiating discounts is not a straightforward thing. I mean, if anyone can walk into a pharma firm and said, give me a 20% discount, and they would give it to them, and everyone would get the discount. It's a tricky business. And if you say to the PBM, we want you to go out there and do all this work in negotiating and discounting and figure out these clever things, working with formularies and so on, and then give all the returns to us, you're not going to get any discounts. What it really does is it puts the onus on the plan to negotiate the discount. If they can do that, fine. Sometimes they can, but sometimes they can't.
Okay. Mr. McNeely.
Yes, I just wanted to weigh in on the fiduciary responsibility piece. We'd have to take another look at the main legislation, but I think we're generally inclined to support that direction if that's direction the committee moves with. Yeah.
Great. Thank you. As you notice, we've got several hearings going on at one time, and I'm going to leave the record open in case any of the members have any questions for the members of the panel. I do want to thank you very, very much for your willingness to come before the committee and help us with our work. This is tough stuff. It's very complicated, but I think you're each in a position that's very, it has a unique perspective, and it's very helpful to us in trying to figure out how what the intended and unintended consequences might be. So I want to thank you for your testimony here, and you're free to go. This hearing is now adjourned.
Thank you, Mr. Chairman, for holding the hearing. Mr. Gingrich, question. Mr. Chairman, and Mr. Lynch very